So this is what I understand about anterior versus posterior approaches of adult deformity. When we look at adult deformity, we encounter so many cases. We encounter cases where there is coronal imbalance as well as sagittal imbalance. We do encounter cases where there is neglected idiopathic scoliosis coming worsened later on during their advanced age. We do see patients where patients are having isolated sagittal imbalance with straight coronal alignment, and sometimes we do see iatrogenic wrongly done surgeries or a surgery which has been failed and led to a coronal imbalance. So all this adult deformity completes the picture of entire spectrum of adult deformities, notwithstanding to this only cases. So I have tried to design this talk in basically 3 parts. With just few slides, 3-4 slides, I would take on the basics of sagittal balance, when we can do MIS deformities and comparison of anterior and posterior. And finally, we'll try to conclude what I think and what I have understood, and would want comments from experts sitting on the panel about the further decision making. So when we look at the spinal balance, the balance is a concept that describes a situation in which the forces present are equal, so that muscles has to act least and we can function in ergonomical fashion without muscles getting fatigued. Hominids modified their profile by developing cervical curvature and a lumbar lordosis by verticalizing the pelvis, and they attained a sagittal upright gait. Then came Dr. Dubos's landmark study, and they started propagating a cone of economy, and they came up with a concept that when human body or a human spine is an inner cone of this cone of Dubose, then muscles are at best advantage and they don't get fatigued even you stand for a very long time. The moment your body starts swaying away from this cone, the outer cone body still can maintain some of the balance with a compensatory mechanism, but once the body moves out of this cone, the spinal balance is totally gone, and patient will be in a highest in disability index. Then the new concept came from European group about again the Dubose group, from the concept of pelvic vertebra. They came that see, when human tried to achieve a upright gait, the lumbar lordosis and cervical lordosis was given, and that led to a verticalization of pelvis. But the reverse is true as per the concept recently, that it is the orientation of pelvis that decides the curvature of the spine. So you are born with a fixed pelvic orientation, and according to your pelvic orientation, gradually your lumbar lordosis, thoracic kyphosis, and cervical lordosis develops. So it is very important to understand the anatomy and orientation of pelvic vertebra. Then in 2002, Dr. Frank Schwab came with a landmark article, and they correlated radiographic parameters with disabilities, and they came up with 4 to 5 factors. One is loss of lumbar lordosis, end plate obliquity, lateral olisthesis, and thoracolumbar kyphosis, out of which one of the most significant factor that led to disability in individual was loss of lumbar lordosis. Cobb angle on coronal plane age has no correlation with the symptoms. So in a nutshell, when your trunk sways significantly in coronal plane or in a sagittal plane, your patient get disabled. If you look at this, another paper from the same group, the ISSG group, they said that as pelvic tilt increases, as SVA falls more and more forward, and as larger PI minus LL mismatch, there is direct and significant correlation with patients' disability indexes. You can see that, beyond 30 degree of PI minus LL mismatch, your patient is almost 80 to 100% disabled. So more PI LL minus mismatch would lead to more SVA falling forward, will lead to more pelvic tilt, and all this composite factor will lead to significant sagittal imbalance. So what is the goal of realignment surgery? Whether you are contemplating an anterior surgery or you are contemplating a posterior surgery, the goal of our realignment surgery is to bring your SVA back to less than 5 millimeter, your pelvic tilt to less than 20 degrees, and spinopelvic harmony, that is PI minus LL mismatch, that is lumbar lordosis in comparison to your pelvic index, less than 10 degrees. As you see on this right side, as lumbar, so out of this, one of the most important factor again turned out to be a lumbar lordosis. As you see on the right side, as patients we start aging, gradual degeneration will lead to significant loss in lumbar lordosis, and which leads to pelvic tilt, which leads to SVA falling forward, and which lead to employment of further compensatory mechanisms. And then came Dr. Ruzzoli, who identified normal group of normal patients curvature in asymptomatic patients. And one of the most landmark thing what he decided and discussed was, it is not the lumbar lordosis globally which is important, it is the distribution of lumbar lordosis which is most important to have least mechanical failure post-operatively. And based on this, the gap score was devised to avoid mechanical complication post lumbar surgery. So in a nutshell, we know that most important thing which decides sagittal balance would be pelvic incidence and correspondingly lumbar lordosis. So lumbar lordosis has become one of the most important factor, and out of all these things, pelvic incidence more or less is fixed, and pelvic incidence would lead to lumbar lordosis. So one modifiable factor, lumbar lordosis, is what we can change during our surgery, and correspondingly we can change the pelvic tilt and further sagittal balance of the patient. Now, to achieve lumbar lordosis, we have multiple options available. Initially started with a PLIF with only contouring the rods. Then came the TLIF, and TLIF, open TLIF started, giving better lordotic correction. Then came the MIS-TLIF, XLIFs, OLIF, and ALIF. So today I'm not going to discuss much about LLIF trans-psoas approaches, because gradually with advent of OLIF anti-psoas approaches, the LLIF are getting obsolete gradually. PLIFs we are not discussing, because in deformity we would want a better lordosis. So PLIFs generally is not considered a very good technique for achieving good lumbar lordosis. So my major focus would be to discuss MIS-TLIF, OLIFs, and ALIFs. Though I am not very proficient in ALIF, but I have, just for the sake of completion of this talk, I have included ALIF into this. So what is an ideal surgical technique? Our ideal surgical technique should be better or yield a comparable results. Technique should not have an unsurmountable learning curve. Technique should persistently reproduce the same good results with acceptable complication profile and affordable to our pocket. And in this particular case, it should give a significant better lumbar lordosis than other technique to consider it as a superior technique. As already discussed in first review of literature, Dr. Mumaneni came with what are the curve that can be included into minimal invasive technique. And basically, I will not go into all subtypes, but mainly three groups they divided: class 1, class 2, and class 3. Class 1 is more or less a compensated sagittal balance, where you can do a MIS decompression or only a segmental fusion. Class 2, where there is not a very high degree of sagittal imbalance, around less than 30 degree of PI minus LL mismatch, and you can do a focal or a curve fusion. And the next would be a massive PI minus LL mismatch, where open surgeries with osteotomies and fusion to higher thoracic spines are indicated. So mainly, according to Dr. Mumaneni, class 1 and class 2 falls into this kind of a group. Well, Dr. Anand, now Neil Anand group has devised, and he has come up with, even in very advanced deformities, they are able to do it. Minimal invasive deformity correction. So to compare different technique, I would want to quote one of Dr. Kim's article here, where they did a match cohort analysis of OLIF and MIS-TLIF technique. The cohort were more or less same in both the groups, and they compared different parameters. Let us look at each of the parameters step by step. Operative time was significantly lesser in OLIF. The estimated blood loss was significantly lesser in OLIF, and postoperative hospital stay was more or less same in MIS-TLIF and OLIF. So OLIF scores over MIS-TLIF in operative time as well as estimated blood loss. When you look at the ODI, there was no difference postoperatively, even at the last follow-up. The clinical result or clinical outcome were both same in OLIF and MIS-TLIF. Now, these are mainly for single or double level cases, not for multi-level deformity surgeries. The VAS for back pain, more or less same. Leg pain, more or less same. The disc height, OLIF and MIS-TLIF, they both had more or less same disc height to start with. And at final follow-up, OLIF could maintain very significantly high rate of disc height. And not only, OLIF was successful in regaining more disc height as compared to MIS-TLIF, it maintained at final follow-up, while MIS-TLIF tend to lose some of the height, maybe because of cage subsidence. Foraminal disc height was again more or less same in both the technique. The most important thing, the segmental lordotic angle was significantly higher in OLIF, and it was maintained all throughout last follow-up. Global lumbar lordosis was more or less not different between two groups, because this was not per se for a deformity. It was mainly for a segmental or two-level study. So when the other disc might have degenerated and may have contributed to loss of lordosis in both the group of the patient. Now, this is another very significant slide, the fusion rate between OLIF and MI-TLIF. If you compare at 6 months, the 80% of OLIF with a statistical significance of 0.04 p-value were fused in OLIF group rather than as compared to 52%. This is why this is very significant, because in major deformity surgeries, it is the early fusion that prevents mechanical complications like screw loosening, cage back out, screw pull out. So we desire early fusion in MIS deformity corrections. When you look at the long term, 12 month and 24 months, there was no statistically significant difference between the two techniques. But the early fusion rate of OLIF over MI-TLIF definitely scores in preventing mechanical complication. So when we compare this head to head in this particular paper, OLIF and MI-TLIF were comparable results as to gold standard. They both had equal steep learning curve. Both had a reproducible result. Both were affordable. In Indian scenario, both are expensive, equally expensive. And complication profile we need to discuss further. Let us look at some of the advantages of lateral minimal invasive surgery or anterolateral minimal invasive surgery. It's a truly minimal access muscle sparing approach. Avascular retroperitoneal spaces are utilized. Direct access to disc space with better visualization than posterior surgeries. It provides us better anterior release. You can release osteophytes, you can release disc annulus, even you can release ALL, which is not required in most of the cases, but in some of the deformity cases, even you can release ALL through the tube in OLIF approach. It achieves indirect decompression and prevents entering into epidural spaces. It leads to a thorough discectomy for a better fusion, large cage with better surface area for fusion, and better lordosis with hyperlordotic cage can be achieved. If we look at few tips about ALIF, ALIF is most significantly used at alpha S1 level, and when you compare with any other trajectory, ALIF is one surgical technique which provides maximum lordosis at alpha S1 in comparison with any other technique possible. If you look at the cage footprint, again, ALIF has the largest cage footprint and would lead to better surface area for fusion as well as better load sharing as compared to other cages. You can see that LLIF also has a better cage. OLIF probably, and of this all anterior surgeries, OLIF cages are the narrowest cages, and there is no comparison with bullet or a TLIF cage in MI-TLIF. If you look at this data summary, more or less ALIF scores most in at alpha S1 as compared to OLIFs and LLIF. ALIF has its own limitations that it cannot be done at higher levels, and it is strictly restricted to L4-5 and alpha S1 in a very experienced hand, or you need an approach surgeon for performing an ALIF surgeries. So when we look at the basic approach related complication between posterior and anterior, posterior may be leading to back pain because of muscle damage. When we enter the epidural space, we are having chances of CSF leak, battered root, neural injuries. Lateral has peculiar like lumboplexus injuries in LLIF, hollow viscous injuries like ureter or a bowel injury, and most catastrophic would be vascular injury. Well, the documented incidence of vascular injury is very less if you exercise proper protocol and you are experienced enough to deal with the surgical area. Then the left-sided approach and anterolateral surgery, the vascular injury chances are minimum. Anterior surgery, alpha S1, ALIF, generally in young patient, you need to use it very cautiously because it leads to retrograde ejaculation. So a lot of mobilization should be avoided. Try to use very blunt sponges rather than using Bowie or cautery. It also can lead to vascular injury. Now, another important thing about anterior surgeries is only achieves adequate indirect decompression, and there is always a fear of inadequate decompression in this kind of procedure. So Dr. Anand group came with a stage procedure when you are performing an anterior surgery, wherein you go for stage 1 with either oblique anti-psoas lateral interbody fusion, or you do an MIS ALIF at alpha S1 level. You make your patient stand next day, get a radiograph done, assess the clinical symptoms, and then go for stage 2 depending on patient. If patient has achieved good sagittal balance, just go in, put the rod, come out. If patient still require decompression, you can do an MIS tubular decompression in that particular patient, and you can utilize rod contouring technique also for achieving better lordosis. And if you find that these facets are fused, facets are not budging, then you may also have to do a MIS facetectomies in this patient in stage 2. So something like this they do first, they put cages anteriorly, they bring the patient back to home, and then finally they put a screw, and next day they do a surgery. So when we compare staged versus a same day surgery, the same day surgery has a length of stay between both of them. Stage where slightly higher length of stay, total operative time obviously was higher in a staged way, anesthesia time was also higher in a staged surgery, and blood loss was obviously high for a staged surgery. When you compare with Cobb angle, the stage surgery had better achieved Cobb angle without statistical significance. The pelvic tilt degree was more or less equal in same day in a stage surgery. Lumbar lordosis also more or less same achieved, but there was significant difference between pre and post-op lumbar lordosis with the stage procedure. Same PI minus LL mismatch was significantly reduced when you are doing a stage surgery, because you can better understand the alignment of spine after insertion of cage. Even SVA fall to less than 5 millimeter was significant in a stage surgery. So what are the contraindication for anterior or lateral approaches when we should only go for posterior? When you see a patient where there is high iliac crest, you sometimes find it difficult to go for LLIF. OLIF, however, can be done very easily for 3-4-2-3, but sometimes L4-5 in a high riding iliac crest, you might have to use specialized instrument, because it's very difficult to achieve an orthogonal maneuver when your iliac crest is coming in your way. So you need to exercise caution while selecting your surgical level, surgical technique in a patient where the iliac crest is significantly high. You need to have a focus on surgical anatomy of your patient before you decide whether you are going for anterior surgery or in a posterior surgery. In my experience, I have seen that majority of Indian patient has a sunken spine with where the bifurcation is generally starts around L4-5 level, not at L5-S1 level in many of the cases. So you need to put a very focused decision making before selecting anterior or lateral procedures. In this kind of a vascular anatomy, it is very difficult to do an OLIF. However, in an expert hand, this can also be done, but with increased chance of complication. You can sometimes have a very outpouting psoas muscle, and retracting psoas muscle will lead to post-operative psoas pain. Sometimes, excessive retraction, even in OLIF, can lead to lumbar plexus injury. So you need to be cautious before selecting this kind of a patient. ALIF contraindications, generally it's majorly unfamiliar approach for those who have not been trained for a general surgery, intra-abdominal surgeries. Calcified aorta or a previous surgery into abdomen for any reason are generally a contraindication for ALIF, and you should go for a posterior deformity correction in this kind of cases. We do encounter cases sometimes where there is significant posterior compression, and this kind of cases, it is important to exercise your wisdom whether you want to choose an interior surgery and come back posteriorly to decompression, or you would want to do all posterior. So why we should derogate MIS-TLIF? MIS-TLIF is overall, it's a single stage procedure, and they say that MIS-TLIF you cannot achieve a lumbar lordosis. If you look at this case, this is one of our case where we did a good bilateral facetectomy, we did a good release of annulus, and we could achieve a very significant lumbar lordosis in this particular patient. The biggest disadvantage or a flip side of MIS-TLIF at multiple level would be that you will have to put so many small cut that it is better to put a large incision on skin and multiple facial stabs at each level. Because the crux of MIS surgery is to preserve muscle, not the skin incision. Same way, if you compare with anterior surgeries, if you look at this, this case, this L5-S1 lateral sided OLIF incision, this is 3-4-4-5 can be achieved from single incision, and the third small incision can do with L1-2 and L2-3 procedures. So 1 to 1.5 inch incision can make you reach to entire L1 to S1 spine in anterolateral surgery. So this is the biggest advantage of anterior surgery over OLIF. If you look at this case, just from a small tiny 2 inches incision, we could get away doing 3-level anterior surgery and small percutaneous cuts in this patient. Now we compare again, head to head with OLIF and MIS-TLIF with open TLIF. And also these three procedures at L5S1, you found that only OLIF could achieve a significant segmental lordosis with statistical significance. Rest of the things could not achieve a very statistically significant lordotic difference between preoperative and postoperative radiologic parameters. The disc height restoration was maximum with OLIF. At L5S1, neither of this technique were effective in significantly restore the segmental lordosis. So finally, when we compare anterior or lateral with MI-TLIF, muscle sparing more or less equal. Lordosis is much better with anterior or lateral surgeries. SVA restoration is better with anterior or lateral surgeries. Coronal cob angle also is better because you can open up the eccentric collapse of the disc with anterior surgeries much better than posterior surgeries. Otherwise, some of the coronal cob angle correction can be done with rod contouring in both the technique. Fusion, as I said, is early and which is advantageous to prevent early mechanical failures in this deformity case patients. PJKs, PJF, jury is still out. We don't have too many high quality evidence to compare anterior surgeries and MI-TLIF with PJKs, but generally it is considered that one of the reason for PJK is a loss of posterior tension band in posterior surgery. So when we are going anterior, we are preserving posterior tension band in most of the surgeries. So as compared to open surgeries, any of the MIS surgeries should be better with PJKs or PJFs in adult deformity surgery. However, there are no large studies available to compare this both of the things. The complication profile, generally the incidence is much lesser in anterior, but if it happens, it could be a catastrophic complication, while MI-TLIF complication profile are more or less acceptable to experienced surgeons. Cost, even with Indian implants, when we compare with MI-TLIF and anterior or anterolateral surgeries, I think cost would be slightly higher, and which is a significant factor when we compare in our Indian scenario. The pelvic fixation is a challenge in anterior percutaneous screw surgeries. However, there could be a modification where you can do a mini open S2AI or a pelvic fixation and then connect it with a longitude rod. But still, pelvic fixation, true percutaneous S2AI or a iliac screw, the system is still not available in our setup. At least, I'm not sure whether it is available in Delhi or Chennai anywhere. So we are not much experienced about percutaneous pelvic fixation in this deformity cases. The stage anterolateral is made generally, ideally should be stage surgery to assess the clinical outcome of the patient, and MI-TLIF is most of the time single stage surgery. So the advantage of anterolateral would be that you still have a leeway to correct your residual deformity even after putting your cage and doing an anterior release, while in MI-TLIF, as it is a stage surgery, you should be to the planning every time to achieve a better result. Decompression in anterolateral is indirect, and MI-TLIF, it is direct. As I said, cost is an important factor that limits us mainly to a focal or minimal fusions rather than going all the way to thoracic and pelvis in our MIS surgeries. So in conclusion, as Dr. Dubose say, whatever you do, whatever technique we employ, the crux of the story is to maintain human body in a cone of economy as described by Dr. Dubose. I would want to quote this paper again from Asian Spine Journal, where they said that the flexion extension lateral view, post-operative segmental lordosis was not significantly different between OLIFs and preoperative film. So they said that isolated anterior OLIF without any posterior maneuvering is not a very useful technique. So there are two takeaways from this article: that one, isolated standalone OLIFs in deformity surgeries are a big no. If you are doing for standalone, if you are doing deformity surgery with anterior surgery, you have to have a posterior fixation, because a lot of deformity correction can be achieved by contouring a rod and rod rotation even in MIS technique. The flip side of this study was, the placement of the cage. If you look at the placement of the cage, it is quite posterior. When you are doing a deformity surgery, the placement of cage and each and every point what you do is very important. When you are doing a surgery to restore lumbar lordosis, your cage position should be significantly anterior, only into anterior third. Then only you can crankshaft and collapse your segment posteriorly by doing a better compression and achieve a better lordosis. L5S1, if you look at in this series, the L5S1, they have done MI-TLIF. When you look at the disc height and restoration of lumbar lordosis is again not adequate, which can be achieved with proper cage position, whether you are doing anterior or posterior. So what you do, which technique you utilize is sometimes less important than how you do that particular technique, which is most important in this patient. Don't forget to use a road rotation technique when you are employing MIS anterior or a posterior surgery. Thank you so much.